Ma'am, we are on live and we are starting the session, ma'am.
Sure, sir, sure.
So, good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. The topic for today's webinar is role of medical nutrition therapy in GDM. So, which is a most important topic as far as GDM mothers is concerned. And now I'd like to welcome today's speaker, Dr. Aabidha Parveen, ma'am. Madam has done her MBBS at DNB OG. And madam is currently a consultant obstetrician and gynecologist, sonologist, infertility specialist, and certified laparoscopic surgeon from Tirunelveli. Madam is currently associated with Crescent Multicare Clinic and Nellai Multicare Clinics in Tirunelveli. Madam has presented various papers in national conferences, published research articles in national international journals, and madam has conducted many free health camps and given many health education for school and college going students. So madam has received various awards to her service and credit. I can highlight few like Sevaratna Award, Maposi Award, Karpaga Virchakam Award, and Kamban Award, and Best Doctor Award from Rotary Club of Tirunelveli suburbs in December 2018. So with this short introduction, we welcome you, ma'am. I'm handing the session to you, ma'am. Over to you, ma'am.
Thank you, Dr. Stalin, and good evening, all doctors, for attending this session, which is more common. Gestational diabetes has become very common nowadays, rather than what we have seen like 5 years or 6 years back. This is in the rising side, because we see actually in general population also we see more of a diabetic patient rather than the normal group. So this has become a major thing now. When we see hyperglycemia in pregnancy has become a major thing now. So every 5 out of 1 patient we see the gestational diabetes mellitus. That too, we have variety of classification, though it can be early type 1 diabetes, which is continuing, or type 2 diabetes, which is like detected prior to the pregnancy. And we see only hyperglycemia in pregnancy, which can be controlled with diet alone. So coming to the medical nutrition in the management of diabetes, before that we will see what is gestational diabetes mellitus, which is defined as impaired glucose tolerance with onset or first recognition during pregnancy. Actually, the women with history of GDM are at increased risk of future diabetes too. Actually, our professors used to say this is a very good indicator for women developing a type 2 diabetes as early as like less than 10 years. She will be prone to be a full-blown diabetic. So pregnancy is a stress, which is a very good indicator for a diabetes mellitus in the future. So coming to the prevalence, we see actually Asian have more probability, that too of 8.7%, particularly Indian women have 17.7% risk of gestational diabetes mellitus. So actually they say the incidence of GDM happens in 7 of every 100 pregnancy. But for the past 5 years, I am seeing for every 5 antenatal women, I am seeing 1 gestational diabetes. So the incidence of GDM in India has increased to 16.58%, almost like 17%, when we take the WHO criteria of 2-hour postprandial glucose of more than 140 milligram per deciliter. So apart from GDM, usually in almost like 1% of the pregnancies, there will be significant disturbance in carbohydrate metabolism. The GDM incidence is increased 8-fold when the women crosses 35 years when compared to women aged 25 years or under. So this is how the burden of GDM prevalence is like 27.6% now, according to the latest studies. Out of 6.2 million live births, which is affected by hyperglycemia in pregnancy, 5.9 million are due to GDM. And we see there is a difference in GDM among rural and urban population. We see less of GDM in rural areas, which is 9.9%, while in urban areas, it is 17.8%. So coming to the classification, we have diabetes in pregnancy and gestational diabetes. This classification, we have to be very clear, because diabetes which is detected prior to pregnancy, whether it is type 1 or type 2, it comes under the classification diabetes in pregnancy. And diabetes first detected in pregnancy, which is type 1 and type 2 also. This diabetes and pregnancy classification, they continue post delivery. But GDM is defined as a pregnant woman who have never had diabetes, but who have high blood glucose levels during pregnancy, and it is transient and usually disappears after birth. Definitely, any pregnant woman who is detected with diabetes during pregnancy has to be followed postmortem, and we have to check her till 6 weeks after delivery. So 85% of the cases are GDM. There is glucose intolerance with first onset during pregnancy, while 15% of the cases will have either pre-existing diabetes antedating pregnancy, or a diabetes which is first detected during pregnancy, that is during the early trimester itself. Why we are more worried about this gestational diabetes? Because it is associated with number of maternal and fetal complications. We have to avoid this complication to bring a healthy mother and a healthy baby. So what are all the maternal complications? One thing is it can be associated with preeclampsia. The second thing is polyhydramnios, prolonged labor, obstructed labor. There will be like a big baby leading to cesarean section, leading to uterine atony, postpartum hemorrhage, and there is a lot of infections like skin infection, urinary infection, vaginal infection, which are associated with gestational diabetes mellitus. Coming to the complications in the fetal side, we have a lot of congenital anomalies associated with GDM. When the HbA1c of mother is more than 8, she's associated with more of the spinal anomalies, heart anomalies, brain anomalies, and there are intrauterine growth restriction, increase in stillbirths, macrosomia, increased respiratory problems in the newborn, jaundice, shoulder dystocia during delivery, leading to birth injuries like Erb's palsy, neonatal hypoglycemia, and infant respiratory distress syndrome. So, as we have told already, 50% of women with GDM go on to develop type 2 diabetes within 5 years of pregnancy, and children born to the woman with diabetic are up to 8 times more likely to develop type 2 diabetes and obesity in their teens and early adulthood. So, if we maintain the glycemia during pregnancy, even though if she is type 1, type 2, or GDM, we can solve a lot of avoid many complications during pregnancy and also delivery, and also we can prevent the children getting so many problems in the teenage and the early adulthood. Coming to the GEDM, the pathophysiology, we have insulin resistance due to placental secretion of anti-insulin hormone. In late pregnancy, there will be maternal hepatic glucose production, which increases by 15 to 30% to meet the fetal demand. And there is a combination of glucose intolerance, hyperglycemia, beta cell dysfunction, and the pancreatic beta cell dysfunction, which is caused by genetics, autoimmune disorders, or chronic insulin resistance. So there are variety of factors which are causing the GDM. Coming to the treatment, ADA and many of the association of OG association, they have recommended diet and exercise are the first line therapy to prevent and correct the hyperglycemia, which is related to GDM. If good metabolic control is not achieved with diet or exercise, then only we resort to pharmacological treatment, either with insulin or oral agents. So, in order to control the course of GDM, you have to monitor the maternal capillary blood glucose level, urine, and blood ketone, which should be monitored frequently. So, all the association, be it a diabetic association, be it a OG association, the first line of treatment for GDM is diet and exercise. That's why we are having this topic for discussion today is medical nutrition therapy for gestational diabetes mellitus. So we all know that GDM can be detected through 75-gram glucose tolerance test, which is patient was given a glucose challenge of 75 grams, 2-hour blood sugar was taken. If it is more than 140 milligram per deciliter, we claim them as a gestational diabetic method. So whenever a woman comes to you for first antenatal contact, we have to do a OGDT test. If the test is negative, the second test should be done at 24 to 28 weeks of gestation. If the GDM pregnant women, we see if it is more than 140 milligram per deciliter, we can manage them with medical nutrition therapy for the first 2 weeks. If it continues, if it is well controlled, we can continue with the medical nutrition therapy itself. If it is not controlled, then only we resort to either oral hypoglycemic agents like metformin or to the insulin. So all pregnant women who test positive for the GDM should be prescribed medical nutrition therapy and physical exercise for 2 weeks. The women should walk or exercise for 30 minutes a day. After 2 weeks, we do a 2-hour post meal. If it is controlled, well controlled, we can continue with medical nutrition therapy and physical exercise, and we can monitor her frequently. If it is not controlled, we have to go for metformin or insulin therapy. Many of the patients, though we see a lot of the patient, 1 out of 5 women being a gestational diabetes mellitus mother, almost like most of them, like 50 to 60% of the patients go well with medical nutrition therapy itself. When it is more only, we resort to either metformin or insulin. So this is how it goes. It is a simple picture. We can, in a pregnant woman with GDM, if we identify, we give MNT, medical nutrition therapy, and physical exercise. 2 weeks later, we do 2-hour PPBS. If it is less than 120 milligram per deciliter, we continue medical nutrition therapy and physical exercise. Monitor 2-hour postprandial blood sugar according to the high-risk pregnancy protocol, or at least once monthly. If after 2 weeks, when we see 2-hour postprandial blood sugar, if it is more than 120 milligram per deciliter, we either start oral antidiabetics like metformin, or we resort to insulin therapy. We monitor fasting blood sugar and 2-hour postprandial blood sugar every third day, or more frequently for insulin, and bi-weekly, that is every 3 days for metformin dose adjustment to maintain the normal blood sugar level. Or if it is a high-risk pregnancy, we have to get a diabetologist opinion. At least 1 monthly we have to. If it is well controlled, we can monitor every monthly. So what is medical nutrition therapy? Like this is like prescribing the nutrition according to the individual standards. So what are our main goals? One is to achieve normoglycemia, prevent ketosis, provide adequate weight gain, at the same time contribute to fetal well-being. So our nutritional plan should be according to each woman, according to her body mass index, according to physical activity level, according to her work level. We have to like allot her calorie allotment, and we have to distribute the calories, and we have to control her carbohydrate intake. So what is healthy eating during pregnancy? So once if she's diagnosed with GDM, we should start her on medical nutrition therapy. It involves a carbohydrate controlled balanced meal plan, which promotes optimal nutrition both for the mother and for the fetus. And we have to provide her adequate energy for appropriate gestational weight gain too. And we have to achieve and maintain the normoglycemia. We see some of the patients, when we resort to, like when we tell them she is diabetic, many of the women are being cut down with normal calories, adequate nutrition, and many come with either ketosis. When they go low down on calories, they come with ketosis. So we have to explain to them properly that proper nutrition, like distribution of both carbohydrates, proteins, and fat should be optimum for both maternal and fetal gain. And moreover, she should not lose weight. The gestational weight gain should be proper. At the same time, we have to maintain the normoglycemia. So individualization is important. We can't just write it as like this woman, we can give calories for uniformly, because the individual, the requirement for the individual varies depending on the energy requirement, depending on the adjustment. We should be made on weight change patterns too. So energy requirement during pregnancy includes normal requirement of an adult and an additional requirement for fetal growth, plus the increase in the body weight of pregnant women. We should not as old people say, we should not tell like we should eat for two. It is a very myth followed by a pregnant women, that they should take calories for both mother and the fetus. No, it should be addition of 350 to 400 calories depending on her increase in body weight, depending on her BMI, depending on her requirement. We have to calculate the calories according to her. So energy requirement usually does not increase in the first trimester unless a woman is very underweight. When the BMI is less than 18 only, her energy requirement should be increased during first trimester. Actually, the energy requirement usually increases during second and third trimester. It should be adequate enough to provide appropriate weight gain during pregnancy. As per Indian ICMR guidelines, an average weight for a normal BMI women, the average weight gain of 10 to 12 kg is sufficient, with an addition of just 350 kilocalorie per day above the adult requirement is recommended during that too in the second and third trimester. Severe caloric restriction should not be recommended at all, as it may result in ketonemia and ketonuria and impair the physical and mental development in the offspring. So how do we calculate the adult? First, we will calculate the adult energy requirement for any women, and then we can add on this plus 350 calories for the pregnant women. So how do we calculate? Usually in a routine, male or female, when we take the energy requirement, it is like calculated according to the basal metabolic rate and the physical activity level. So the basal metabolic rate for an adult female of 18 to 30 years, it is calculated by the formula 14 into your body weight in kg plus 471. While in BMR for adult females aged 30 to 60 years, it is calculated by the formula 8.3 into body weight in kg plus 788. So pre-pregnancy body weight is taken into consideration when calculating this requirement. So how will you like according to the we have to educate the field level workers. So it has to be made simple. We can't ask them to calculate with the high-fi formula. So for the field workers, we have to educate them when they are of sedentary works, when they don't have any work to do. The energy requirement during pregnancy is 1,000. For an adult female, it is 1,900. So we add extra 350 calories, so it is 2,250 kilocalories per day. For a moderate work women, it is 2,230 plus 350. So it becomes 2,580. So for heavy work women, it is 2,850 plus 350. So it is 3,200 kilocalorie per day. So when we take a pre-pregnancy weight, like we either add or deduct the 500 kilocalorie per day according to the underweight or obese women. So when in underweight women, when the BMI is less than 18.5, we can add 500 kilocalories to the energy requirement, basal energy requirement. In a normal weight and in overweight women, when the BMI is 18.5 to 25, we can maintain the requirement as we have calculated already. While in obese individuals, if it is BMI is more than 25, you can calculate the energy requirement plus 350 for the pregnancy, and you can deduct 500 kilocalorie per day as she is obese. So even in a obese women with GDM, the calorie should not be so low that it can adversely impair the fetal growth besides ketonemia and ketonuria. So moderate calorie restriction, that is reduction by only 30% of the estimated energy needs in obese women, will improve the glycemic control without ketonemia, and it also reduces the maternal weight gain. It will optimal weight gain will be achieved. So whatever we have calculated the calories now how we are going to distribute it is. Then now we are talking about calorie allotment. Coming to the carbohydrates, actually we all know carbohydrate foods are essential for healthy diet for both mother and the baby. Once digested, these carbohydrate foods are broken down to glucose, which goes into the bloodstream. So the type, amount, and the frequency of carbohydrate intake has a major influence on the blood sugar readings. So when we prescribe carbohydrates for the mother, we include cereals like wheat, bajra, ragi, rice, corn, and its products like suji, refined flour, breads, pasta, and noodles. Pulses like green gram, Bengal gram, black gram, starchy vegetables like potato, sweet potato, corn, tapioca, fruits, sweets, and juices. These are all carbohydrate content. When this carbohydrate also should not be taken in a large amount, that too at a single serving. So this, if it is taken at single serving, when we take larger amount of carbohydrate, it will lead to high blood sugar level. So it should be avoided. The carbohydrate food should be spread over the day to maintain the normoglycemia equally at all time of the day. So it is better to spread carbohydrate foods over 3 meals and 3 snacks each day rather than taking 3 large meals. So whatever we follow is 3 meals, 3 large meals. But in a pregnant diabetic women, or not only pregnant diabetic women, we are always prescribed diabetic individuals with 3 meals and 3 snacks, which is spread over 3 hours intervals in a day, so that their glycemia is maintained throughout the day uniformly. Or else when we take food, after 2 hours, there will be a high peak in the blood sugar level. But after 4 hours post meal, there will be a dip in the glucose levels. So that should not occur. Hyperglycemia and the dip should not occur. We have to maintain the glucose level in the very tight control, that too in pregnancy, because we aim at a blood sugar level of 140 usually during pregnancy at all time. When it is like too low also, it is detrimental to the baby. When it is too high also, it is detrimental to both mother and the baby. So in order to take carbohydrates better, it is better to take complex carbohydrates rather than simple carbohydrates. Complex carbohydrates like whole grain cereals like oats, bajra, jowar, ragi, whole pulses, vegetables, fruits with skin. Ideally, rather than giving them juices, it's better to take them fruit with skin so that the fiber content will be added and they can take it in. They will feel early satiety too. And simple carbohydrates like food with lots of added sugar or honey and foods that are made from refined white flour should be avoided. So all three ways like rice, sugar and salt can be avoided. That to maida can be avoided by GDM method. Similarly, many people think like only sugar is sugar. This jaggery, palm sugar, this can be taken. No, that is also a like sugar that gives that also causes hyperglycemia. So when you want to take milk or tea or coffee also, that should be without any sugar. And similarly, sweets, cakes, puddings, biscuits, pastry items, juices, soft drinks, white bread, non-pizza also should be avoided. And we have to like count the number of carbohydrate serves that a mother eats during the day so that it will help her to eat the right amount of carbohydrates. So our aim should be to take 2 to 3 carbohydrate serves at each major meal and 1 to 2 carbohydrate serves at each snack. So one serve is usually approximately 15 grams of carbohydrate. So with each major meal, she can take about 45 grams of carbohydrate, but at each snack, she can take about 15 grams of carbohydrate. So energy and carbohydrate levels, they coming to the actually our clinical goals for medical nutrition therapy for GDM are twofold. One is to meet the maternal and fetal nutritional needs to achieve and maintain optimal glycemic control. So these are like both edges of the weapon. It has to be like tightly controlled. We have to meet the maternal and fetal needs. At the same time, we have to maintain the optimal glycemic control. So both ADA and ACOG have issued recommendations for GDM management. Like it is like nutrition recommend during pregnancy are similar for women with or without diabetes. Only thing is like we are emphasizing the food choices to promote appropriate weight gain and also normoglycemia without ketonuria. So these are all the latest ADA and ACOG guidelines. According to the ADA guidelines, the last recommendation during 2004 is there should be a modest kilocalorie restriction of 30%, 3 meals and 2 to 4 snacks, moderate carbohydrate restriction. Similarly, in ACOG criteria, they have also prescribed like modest kilocalorie restriction of 30 to 33%. That too in obese individual, it is 2000 to 2200 daily calorie range. And based on the obesity, they can cut down on the kilocalorie prescribed. Either for a non-obese women, it is 30 kilocalorie per kg, while in obese women, it is 25 kilocalorie per kg. So they at last they recommend what is like a more that should be a modest carbohydrate restriction, 35 to 40% of kilocalories per GDM. So it is this has been associated when we restrict too much calorie restriction, which we have implicated earlier, like 55% when compared to 40% of the total energy, there is deterioration in glycemic control and also accentuation of the hyperinsulinemia among persons with type 2 diabetes as well as pregnant women with GDM. So always it is not strict carbohydrate restriction. It should be a modest carbohydrate restriction. This is how we have many study groups have conducted each and every time for overweight, obese, GDM diet, how the calorie restriction, but they all have come to a conclusion of there should be a modest restriction for a lower maternal weight gain, and also there should be any normal birth weight compared to less ketonuria and ketonemia. So we have talked about carbohydrate intake, how we have to take. One thing it should not be too much cut down on calories. You can give in servings. Major meals, it should be 2 to 3 servings, while in the snacks it can be 1 to 2 servings. This complex carbohydrates are better than simple carbohydrates. There should not be too much cut down in calorie to produce ketonemia or ketonuria. That's our goal in carbohydrate intake. Coming to the fat intake during pregnancy, saturated fat intake like ghee, butter, coconut oil, palm oil, red meat, organ meat, full cream milk should be less than 10% of the total calories, and dietary cholesterol should be less than 300 milligram per deciliter. In obese and overweight patients, a lower fat diet overall can help slow the rate of weight gain. So we should not like dump them with more fat intake, leading to increased weight gain. Because we know that maternal obesity will cause major complications apart from GDM complications. So ways to trim the fat from your diet, how you will like cut down the fat from your diet. One thing is you can use less fat in cooking, and you can avoid frying of foods, using low fat dairy products in place of whole milk or milk full cream products, using low fat snacks like substituting with fresh fruit, salads, baked and steamed food items for high fat snacks such as cakes, biscuits, chocolates, pastries, samosas, and pakoras. So using lean meat in place of red meat. So these ways we can trim the fat from your diet. So coming to the protein requirement in pregnancy should be increased actually additional 23 gram per day to allow for fetal growth, because we are cutting down the carbohydrate and also fat. So in that, to compensate for the calorie requirement, you have to add protein requirement. That will help in like maintaining the normoglycemia, and it also like decreases macrosomia while providing additional nutrition to the mother and the fetus. Because many times like GDM is associated with gestational hypertension or preeclampsia, leading to IUGR, intrauterine growth restriction. So the protein requirement in pregnancy should be increased in this women. At least 3 servings of protein foods are required every day to meet the increased demand. The sources of protein are either it could be milk and milk products, egg, fish, chicken, pulses like dal and nuts. And the fiber content should be more. It also helps in a major role in helping controlling the blood sugar by delaying the gastric emptying, retarding the entry of glucose into the bloodstream, and lessening the postprandial sudden rise in blood sugar. Coming to the like fibers, like soluble fiber in flax leaves, xylem husk, oat bran, legumes, dried beans of all kinds, peas and lentils, pectin from fruits such as apples, and forms in root vegetables such as carrots are very helpful in providing this fiber content. Coming to the folic acid, actually we all know that folic acid plays a major role in neural development of the baby. Even it can like pre-pregnancy like supplementation of folate can lead to lot of decrease in neural tube effect. So it is involved in cell multiplication and DNA synthesis. The requirement is 600 microgram per day during pregnancy. The deficiency may result in neural tube defects, Down syndrome, preterm delivery, elevated serum homocysteine levels. So they have like found many beneficial effects of folate supplementation both during pregnancy and also pre-pregnancy. Calcium and iron, like as in any pregnancy, it is 1300 milligram for ages 14 to 18 and 1000 milligram for age 19 to 50. We need about additional 1000 milligram of iron during pregnancy approximately, which is 3 milligram per day. The two we recommend 30 milligram ferrous iron as an iron supplement in the second and third trimester, and screen women for iron status during pregnancy, because in GDM mother there is a lot of chance of macrosomia leading to uterine atony. There is increased case of postpartum hemorrhage. So throughout the pregnancy, iron should be supplementation should be followed, and hemoglobin should be monitored frequently. So the meal plan composition should be, it is like the recommended composition for the GDM positive mother is 50 to 60% calories from the carbohydrate, 10 to 20 from the protein, and 25 to 30 from the fat. The distribution should be like it makes particularly carbohydrate makes a difference in the postprandial blood sugar. The total intake of carbohydrate should be controlled and monitored, and carbohydrate foods that too with a lower glycemic index like complex carbohydrates and fiber content should be emphasized. There should be always a mixed meal consisting of carbohydrate, protein, fat, and fiber eaten together results in slow blood sugar rise. Food items that increase the blood sugar rapidly like sweets, processed fruit juices, aerated sweetened drinks, rice, potato, fried food, red meat should be avoided. So important tips for planning meals for GDM positive mother is, one thing is she should follow discipline regarding the meal timings. I had one patient who is like 6 years, who conceived after 6 years of infertility treatment. She is a so nice mother. She had come with diagnosed with the GDM at 16 weeks. At that time itself, her sugars were too high. It is like 260 in the GCT, the glucose challenge test itself. So all her fasting and postprandial was high. We prescribed medical nutrition therapy initially, but she's not controlled because both her parents were diabetic. So we admitted her almost like in total antenatal period. We were about to we have admitted her for almost like 3 times to maintain her sugar level. We have given her with insulin, but the thing is, like, with all the complications, she is obese. But every day I still remember her. She had a pocket diary. She used to write every day meal, what she had eaten and what she had taken, how much serving. That's how, with all the complication, we could take her up to like 37 weeks. We could deliver a beautiful baby of 3.6 kg. She named her son after my son's name because she could take the baby home happily. That's how, like, I appreciate her. And I have kept her diary, and I have told all my GDM patients afterwards, like, how she meticulously, even nowadays, like, no people follow like her. Like, she used to write each and every day's meal plan in a small packet diary, and she used to carry that with her. So with almost high sugars, she was able to control that sugar because of this medical nutritional therapy. Similarly, eating heavy at one meal or skipping any meal or fasting for long hours should be avoided. We see many pregnant women who take dinner at 8 o'clock and morning they take breakfast at 11 o'clock. This should be avoided because if they take dinner at 8 o'clock, there will be definitely a dip in blood sugar level around 2 or 3 o'clock. So according to Down and Somaji phenomenon, we will have fasting hyperglycemia. It should be avoided. There should not be a fasting for long hours too. And she should include all food groups in her daily diet, that is cereal, pulses, milk and milk products, fruits, vegetables, and fats. For non-vegetarian mothers, eggs, low-fat meat like well-cooked fish or chicken can be included. Meal plan should be divided into 3 major meals, as we have told already: breakfast, lunch, and dinner, and 2 to 3 midday snacks. So midday snacks, usually it can be spread over in a day with 2 to 3 healthy midday snacks. 1 to 2 carbohydrate serving can be taken. A mother should to maintain a 2 to 3 hour gap with major meal when taking the midday snack. Eating fried foods or junk food should be avoided. Either they can take like vegetable poha, idli, sprouts, besan chilla. Actually, in our country, we can sprouts are best recommended. They can take cucumber, they can take carrot, they can take sprouts, they can take like sundal, or fruits with a low glycemic index like apple, sapota, or that can be like if one fruit a day they can take. So general tips: fried food should be avoided. Rather, mother can steam, boil, or saute food in less oil. Whole fruits are preferred rather than juices. Prefer fish or chicken over red or organ meat. Fiber should be increased in the diet by including salad, beans, non-starchy vegetable, whole fruit, whole grain cereals, whole pulses. Mother should drink water, buttermilk, homemade soup, soya milk, and other unsweetened healthy beverages instead of soda or fruit juices. So key messages is medical nutrition therapy is the bedrock for managing GDM. Many different approaches to the nutrition therapy work and are equally effective, provided mother follows it very meticulously and sincerely. More than restriction, it is important to focus on the quality of carbohydrates and encourage the consumption of vegetable, fruits, complex carbohydrates, and high fiber diet. Monitoring the gestational weight gain, self-monitoring of blood glucose and fetal growth is important to modify nutrition advice to achieve optimal outcome for the mother and the newborn. So whenever a mother is diagnosed with GDM, I usually advise them to take a glucometer so that they can monitor every third day, and then like they can message me. So they can come for follow-up every 2 weeks, because there should be a proper rapport between the gynecologist and the GDM mother, because they have to be followed throughout. We see many of sudden intrauterine death in GDM when it is not controlled. So the GDM mother has to be carefully monitored, and you have to be to bring a healthy mother and the baby. Thank you so much for your patient listening. And then thank once again the Shield Connect and the entire members for continuing medical education service throughout. Thank you so much.
Thank you, ma'am. Thank you very much for that one more awareness webinar, ma'am. So yes, ma'am. As you said, GDM is also another one major issues when a woman gets conceived, ma'am. Ma'am, let me wait for 1 or 2 minutes for the
Sure,
participant.
sure, sure.
Ma'am, if there is any queries, then I'll read it for you, ma'am. Participants, if you have any queries, you can just post in the chat box. We can have a short QA session. And ma'am, you are saying like first the GDM has to be monitored in the first antenatal visit. If she is not diabetic, then we can go for 34 to 24 to
24
28
to
weeks.
28 weeks. Yeah, we can
So,
repeat.
ma'am, whether is that right, or we should monitor every month, ma'am? So that why, because
Actually, we in Tamil Nadu in government program we have GCT done at each trimester. So
okay, ma'am.
even if we don't do like all mothers registered AMC under Tamil Nadu government program, they are monitored glucose challenge test every trimester. Every 3 months they are being monitored. That's quite fine.
Okay,
So even when we do at 24 to 28 weeks, and we repeat one another at 32 to 34 weeks also.
okay, ma'am. Ma'am, as you also said that we have to the GDM mother has to divide her food and eat, ma'am. And
Yeah,
when it comes to fruits, all fruits don't have this
yeah.
same glycemic index, ma'am. So it may be high in some fruits. So the mother may think that she may take any fruits so that she can control her glycemic content, ma'am. So we have to say that they should take the fruits of low glycemic content.
Yeah,
It's also
that's
an
true, sir.
important
We
point.
always like in Tamil Nadu, we recommend like they should avoid mukkani actually. They should
Yes,
avoid bananas, which is with high glycemic index. They should avoid mangoes. They should avoid jackfruit. The rest of the fruits can be in moderation that they can take. Not all fruits in a single day. Like in serves, they can take one fruit a day, like apple 3 pieces, guava 3 pieces, like that. Like, they can the mid snack can be like comprised of this one type of fruit with low glycemic index.
okay, ma'am. Ma'am, if the glycemic content is high, like around 250 or 260 at the time of delivery, whether you will be doing this cesarean session, or we have to wait, or they have to control the blood glucose level, ma'am. How it is,
No,
ma'am?
that doesn't depend on the only sugar level. That has to be like it depends on the maternal condition, like how is the cervix, how is the contraction. Like usually all GDM, if it is well controlled, we usually deliver at 38 weeks. Depending on her cervix, like we can induce her.
Okay,
Like in labor also, we have to monitor her properly. Like every fourth hourly, we do sugar levels. So it doesn't if it is too high, as you say, even then we can allow her for normal delivery, and we can start her on insulin drip to maintain her glycemic levels during labor. So
okay,
sugars alone is not a criteria for a cesarean section.
okay, ma'am. So, ma'am, post delivery, whether she need to continue the diet or
Definitely. Actually, post delivery, as they are like in with us, usually we continue post operatively or post delivery 24 hours. We monitor sugars every fourth hourly. Then, depending on her glycemic control, if it is like normal, then the next third day we do fasting postnatal. If it is well controlled, we usually send her home. Then we ask them to come back for every review. Like 2 weeks later, we can check her sugars. But after 6 weeks, she has to be OGTT has to be done for her. Like 100-gram glucose challenge test, you can do a fasting 1 hour, 2 hour, and 3 hour glucose test to know that whether it is gestational diabetes, that is, it is weaning off after pregnancy, or she is continuing to be diabetic. So always like 6 weeks postpartum, we have to do a OGGT to confirm whether she is continuing or it is only GDM.
okay. Ma'am, what about the risk of PCOS, ma'am, in this GDM? Whether the mother can transfer the GDM, that is diabetes, to their child?
Actually, the incidence of GDM is higher in PCOS women. Women with PCOS actually always have a basic pathology of insulin resistance. So that's why we advise women with PCOS to continue that metformin even when they get pregnant for the first 3 months. So that will reduce the incidence of GDM. Compared to general population, the PCOS have higher incidence of GDM. So they also have to be properly monitored. As you said, they come under high risk pregnancy. So in that patients, we can monitor their sugars frequently.
Okay, ma'am.
Though it is PCOS or non-PCOS, GDM mother always like transmit the type 2 diabetes to the newborn, like when they come to adulthood, like which is 8 times more when compared to the general population.
Fine, ma'am. Ma'am, there is no other questions in the chat box, ma'am.
Okay, sir.
So, ma'am, if you allow us, then we can end the webinar for today.
Sure, sir. Sure, sure.
Yeah,
Thank you.
ma'am.
Thank you
Thank
so
you,
much.
ma'am. Thank you very much for being with us and spending your valuable time with us once again today, ma'am. I'd also like to thank our EvaCare team for arranging such a important and awareness webinar, ma'am. Thank
Thank
you,
you.
ma'am. I would like also thank our audience for their active participation and patient listening, ma'am. Thank you, ma'am. Thank you, Nanda.
Thank you, sir. Thank you so much.